Hello everyone. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be discussing a very important form of vasculitis, that is the microscopic polyangiitis. So microscopic polyangiitis, it is a form of small vessel vasculitis. Right? It is a form of the small vessel vasculitis. So you should know what are the vessels which are affected in the microscopic polyangiitis. So it is mainly the disorder of the small vessels. Right? It is mainly the disorder of the small vessels. And followed by that, there is also involvement of the medium-sized vessels. Right, followed by that there is involvement of the medium-sized vessels. So these are the vessels which are affected in the microscopic polyangiitis, and these small vessels, they include involvement of the capillaries, venules, and then arterioles. Okay, so these are the vessels which are affected in microscopic polyangiitis. And what are the other examples of the small vessel vasculitis? The other examples of small vessel vasculitis, that includes Wegener's granulomatosis, then Churg-Strauss syndrome, and then we have Henon-Schollen's purpura. So these three are the other examples of your small vessel vasculitis apart from the microscopic polyangiitis. And let me tell you that in patients with the microscopic polyangiitis, it is ANCA associated vasculitis. Almost 75% of cases, right? 75% of cases, you have the presence of the microscopic, 75% of cases of microscopic polyangiitis, you have the presence of the p-ANCA. Right, you have the presence of the p-ANCA. Okay, next, then followed by that, let me tell you that microscopic polyangiitis, it is a pauci-immune non-granulomatous necrotizing vasculitis. So what is the type of inflammation? It is non-granulomatous necrotizing inflammation, and that affects mainly the small blood vessels. Right, that affects mainly the small blood vessels. So what I mean to say is, already I have said you this point that it is a small vessel vasculitis, but in this small blood vessels, you have the presence of non-granulomatous necrotizing vasculitis, and this microscopic polyangiitis often causes glomerulonephritis and pulmonary capillaritis. Okay, it often causes glomerulonephritis and pulmonary capillaritis. Okay, right, that is what you will observe in microscopic polyangiitis. And this microscopic polyangiitis, it is often associated with ANCA. Right, and what is the type of ANCA? That is the p-ANCA. Right, that is your p-ANCA. Okay, and this p-ANCA, it is the antibody which is directed against myeloperoxidase. Right, which is directed against myeloperoxidase. So if you see this myeloperoxidase, it is the constituent of the neutrophil granules. Right, it is the constituent of the neutrophil granules. Okay, so that is about your the basic introduction to your microscopic polyangiitis. And if you take the comparison of this microscopic polyangiitis with the polyarteritis nodosa, see, you take in case of the polyarteritis nodosa and granulomatosis with polyangiitis, the comparison, Because the microscopic polyangiitis may involve the medium vessels as well as the small vessels, but predominantly microscopic polyangiitis, I have said you, small blood vessels. And because it tends to affect the capillaries within the lungs and kidneys, its spectrum overlaps those of both polyarteritis nodosa and granulomatosis with polyangiitis. So granulomatosis with polyangiitis is nothing but your Wegener's granulomatosis. Okay, so the spectrum of microscopic polyangiitis that will overlap, right, that will overlap the polyarteritis nodosa and as well as the granulomatosis with polyangiitis. Now, apart from that, there are certain drugs that induce the systemic vasculitis associated with high titers of p-ANCA. Okay, now, what are those drugs that induce a systemic vasculitis associated with high titers of p-ANCA? There are certain medications or there are certain drugs. And what are those medications or drugs? Number one, propylthiouracil. So propylthiouracil, it is an anti-thyroid drug, which is a thyroid peroxidase inhibitor. Then we have hydralazine. So hydralazine, it is an arteriolar vasodilator, right, which is used in the treatment of the hypertension. Then we have another important drug, that is allopurinol. Allopurinol, it is the xanthine oxidase inhibitor, which is used to reduce uric acid levels in patients with gout or gouty arthritis. Then we have penicillamine. So penicillamine, it is a drug used in the treatment of rheumatoid arthritis, and it is also the drug used in the treatment of the Wilson's disease. Then we have minocycline, right? So this minocycline, it is an antibiotic. And then we have sulfasalazine. Sulfasalazine, it is the drug used in the treatment of the rheumatoid arthritis. So please remember, these medications, right, they induce a systemic vasculitis, right? They induce a systemic vasculitis associated with high titers of the p-ANCA, right? They induce the systemic vasculitis with high titers of the p-ANCA, right? And these drugs will induce the vasculitis which have the features, right, which have the features similar to that of microscopic polyangiitis, right, which have the features similar to that of the microscopic polyangiitis. So this slide is very, very important, right? The drugs which are associated with high titers of p-ANCA and features of the microscopic polyangiitis. And if you observe the signs and symptoms of microscopic polyangiitis, a wide variety of findings suggesting vasculitis of small blood vessels may develop in microscopic polyangiitis, right? A wide variety of findings, and these include, right, the development of the palpable purpura, right? These include the development of the palpable purpura, right? And other signs of cutaneous vasculitis. And this palpable purpura, let me tell you, they are raised palpable purpura, right? And other signs of cutaneous vasculitis. So what are those? Other signs of cutaneous vasculitis. Other signs of cutaneous vasculitis include the development of ulcers, right? Development of the splinter hemorrhages and vesiculobilous lesions. Right, vesiculobilous lesions. So these are the other signs of the cutaneous vasculitis, right? But the most common thing will be your palpable purpura. Okay, and this microscopic polyangiitis is the most common cause for pulmonary renal syndrome, right? It is the most common cause for development of right, development of the pulmonary renal syndrome. This pulmonary renal syndrome, you know, most common cause for the development of this pulmonary renal syndrome is microscopic polyangiitis, right? And it being several times more common than anti-glomerular basement membrane disease. See, where is that you will have this pulmonary renal syndrome that is in patients with, right? That is in patients with good pasture syndrome. So even in good pastures, you know, you have this pulmonary renal syndrome. And this good pasture syndrome, it is nothing but anti-glomerular basement membrane disease, right? Anti-glomerular basement membrane disease. So, but compared to your good pastures, microscopic polyangiitis, that is the most common cause for the pulmonary renal syndrome. So, because of this pulmonary renal syndrome, what will be the clinical manifestations? So, if you observe the pulmonary manifestations include the development of the pulmonary hemorrhages. Pulmonary hemorrhages may occur with pathological findings typical of the capillaritis. And other important pulmonary manifestations that you will see in microscopic polyangiitis is interstitial lung fibrosis. Right, interstitial lung fibrosis. So this interstitial lung fibrosis that mimics usual interstitial pneumonitis, which may be a part of presenting condition and that convey a poor prognosis. So if there is development of interstitial lung fibrosis in patients with microscopic polyangiitis, these individuals, they have poor prognosis. Right, these individuals, they have poor prognosis. Then development of vasculitic neuropathy, right? And this vasculitic neuropathy is what? That is nothing but mononeuritis multiplex. Right, that is mononeuritis multiplex. So mononeuritis multiplex is also common in patients with microscopic polyangiitis. So why is this due to? That is due to vasculitic neuropathy. Right, that is due to vasculitic neuropathy. So these are the signs and symptoms of the microscopic polyangiitis, that is your pulmonary renal syndrome. But actually the skin manifestations will be in the form of the palpable purpura, right? And other signs include the other features of cutaneous vasculitis include ulcers, splinter hemorrhages, and vesiculobullous lesions. Okay, and as a part of your pulmonary renal syndrome, they can have this pulmonary hemorrhages. And if they develop interstitial lung fibrosis, that tells you or that conveys a poor prognosis within the individual. And mononeuritis multiplex is another important finding. Next. And if you take the laboratory findings in these patients with the microscopic polyangiitis, 3/4 of patients with microscopic polyangiitis, they are ANCA positive. Right? So in 3/4 of the individual, you have the p-ANCA being positive. Okay, and this p-ANCA, it's an antibody which is directed against myeloperoxidase, right, which is directed against myeloperoxidase. And because of the presence of this p-ANCA, it will cause a p-ANCA pattern on immunofluorescence testing, right? So immunofluorescence testing, that will show you the p-ANCA pattern on immunofluorescence testing. Right, and the next important thing is ANCA, which is directed against proteinase 3, can also be observed in minimal group of individuals. And ANCA, which is directed against your proteinase 3, is your c-ANCA. Actually, c-ANCA, it is a feature in case of veg nuts, but in p-ANCA, remaining 1/4, you can have that particular c-ANCA. Okay, and the other point, so please don't get confused. Okay, right, it is direct lines from your CMDT. In 75% of individuals, you have p-ANCA in patients with microscopic polyangiitis. Right, in few individuals you can have ANCA which is directed against your proteinase 3, which is nothing but c-ANCA. Okay, right, and you take, there is also elevated acute phase reactants. Right, there is elevated acute phase reactants, and when there is elevated acute phase reactants that are typical of the active disease, right, that are typical of the active disease. Next, now if you do a urine examination in these patients with the microscopic polyangiitis, urine examination will show you the presence of microscopic hematuria, right, and there can be even proteinuria, right, and there is presence of RBC cast in the urine. Okay, so this is what the urine examination in patients with the microscopic polyangiitis, right? And if you observe the kidney lesions, so the kidney lesions, they are segmental, right? Kidney lesions, they are segmental, necrotizing glomerulonephritis. Right, segmental necrotizing glomerulonephritis, and it is often with localized intravascular coagulation. So there is also right, there is also intravascular coagulation that can be seen within the kidney, that is intraglomerular thrombi can be seen upon the renal biopsy. So that is what the kidney lesion seen in patients with the microscopic polyangiitis. So then how do you treat these patients with the microscopic polyangiitis? So microscopic polyangiitis is usually treated in the same way as granulomatosis with polyangiitis, that is wedge nuts. So in patients with severe disease, like typically involving pulmonary hemorrhage, or in patients involving glomerulonephritis, these patients, they require urgent induction with steroids. Okay, so patients, right, patients with severe disease like pulmonary hemorrhage, and glomerulonephritis, these lesions, if they are there, they require urgent induction. Right, they require urgent induction with corticosteroids. Right, and you should give either cyclophosphamide or rituximab. Right, cyclophosphamide or rituximab. Okay, so this is what is the treatment of the microscopic polyangiitis. So it is in severe disease involving pulmonary hemorrhage and glomerulonephritis. They require urgent induction treatment with steroids and either cyclophosphamide or rituximab. Next, following successful induction of remission, right, following successful induction of remission, if cyclophosphamide is chosen, it may be administered either in an oral daily regimen or via intermittent intravenous pulses. Okay, so following the successful induction of remission, this cyclophosphamide is given, right, it is chosen, and this is administered either as oral daily regimen or via intermittent intravenous pulses. Okay, so that will be following successful induction of remission. And following successful induction of remission, treatment should be continued with your cyclophosphamide, and along with that, you also need to continue the azathioprine. Right, you also need to continue the azathioprine. So in case of the severe disease, like when there is pulmonary hemorrhage and glomerulonephritis, I said you require urgent induction with steroids and either cyclophosphamide or rituximab. And if at all, if you are giving cyclophosphamide, that is daily oral regimen or intermittent intravenous pulses. Right? And along with that, the treatment should also include azathioprine or rituximab or methotrexate. Right, or methotrexate. Okay, but only thing, you have to ensure that the individual has a normal kidney function. Right, whenever you are giving this azathioprine, rituximab or methotrexate, you have to ensure that the patient has the normal kidney function. So this is about the treatment of microscopic polyangiitis. And if you see the prognosis, the key to affect the good outcomes is the early diagnosis. So if you want to have a good prognosis, right, or if you want to have a good outcome, right, early diagnosis is very much required in these patients with the microscopic polyangiitis. So compared with patients who have granulomatosis with polyangiitis, those who have microscopic polyangiitis are more likely to have significant fibrosis on renal biopsy because of later diagnosis. So the point is that when you do a later diagnosis, that means a delayed diagnosis, right, there is a very high chance that there can be development of there is very high chance that there is development of significant fibrosis, right? And the likelihood of the disease recurrence following the remission in microscopic polyangiitis is about 33%. Okay, so the chance of recurrence in microscopic polyangiitis, it is 33%. So this is about your microscopic polyangiitis. So please remember, microscopic polyangiitis, it is a form of the small vessel vasculitis, right? And it is an ANCA positive vasculitis. And the type of inflammation is non-granulomatous necrotizing inflammation, right? And small vessels like capillaries, venules or arterioles are affected. And it often causes glomerulonephritis and pulmonary capillaritis. And it is an ANCA positive against your myeloperoxidase, right? And you need to know the drugs that induce a systemic vasculitis associated with high titers of p-ANCA. And these particular drugs include propylthiouracil, hydralazine, then allopurinol, penicillamine, minocycline, sulfasalazine. Okay, and signs and symptoms, the cutaneous manifestations, palpable purpura is very important, and other cutaneous manifestations like ulcers, splinter hemorrhages, and vesiculobulous lesions. And pulmonary renal syndrome, the most common cause for pulmonary renal syndrome is microscopic polyangiitis, and we have also other causes like Goodpasture syndrome. But rather than Goodpasture syndrome, your microscopic polyangiitis is the most common cause for pulmonary renal syndrome. Okay, and pulmonary manifestations will be in the form of pulmonary hemorrhage. And if these patients with microscopic polyangiitis, if they have interstitial lung fibrosis, that tells that the individual had a very bad prognosis or poor prognosis. And vasculitic neuropathy will be there, due to which they will develop mononeuritis multiplex. And investigations, almost 3/4 of the individual, they have the p-ANCA, right? And acute phase reactants, they are elevated. ESR and CRP are elevated. And urine examination show microscopic hematuria, proteinuria, and there is also RBC cast in the urine may be there. And the kidney lesions, they are segmental, necrotizing glomerulonephritis, often with localized intravascular coagulation. That means when you do a renal biopsy, you have the presence of the intraglomerular thrombi. And treatment, if you observe in case of microscopic polyangiitis, right, in severe form of the disease, they require urgent induction of treatment with corticosteroids, and either cyclophosphamide or rituximab should be given. And following successful induction of remission, right, with cyclophosphamide, the other drugs that can be added is azathioprine, rituximab or methotrexate, but only you need to ensure that the individual has normal kidney function. Prognosis, let me tell you, if the early diagnosis is there, then the outcome will be good. But if it is a delayed diagnosis, renal fibrosis will occur, more common than compared to that of your Wegener's granulomatosis. And even after complete remission, the chance of recurrence in case of microscopic polyangiitis is almost 33%. Right? So this completes the discussion of this very important topic, that is microscopic polyangiitis. Thank you very much.